All right, thank you. And just, I was ambitious on this topic and I wanted to add coronary flow reserve, but I simply just didn't have enough time. There's so much to talk about in cardiac PET, so, I do apologize. I couldn't quite get into CFR. And we do it routinely in clinical practice in my institution, and I can answer questions. I thought I'd add, this is, anybody that wants to come to Virginia, that's my facility in the valley. We're surrounded by mountains. It really is. It's a beautiful place. My goals here: information about cardiac PET CT. I understand that you guys are in the process of doing this. That's fantastic. I can tell you this is uncommon in the United States. So with the challenges of getting rubidium, there are probably, it varies a little bit, but only 15 to 20 places in the United States that do cardiac PET CT. And we have 350 million people. So, these are typically academic institutions. And simply, as you'll find out, the people that work, this is a pain. This is challenging, to figure out, to get the material on site, to use the rubidium generators to maintain a consistent source. But we'll get into that a little bit. So I want to identify some of the challenges to incorporate transitioning into cardiac PET. I'll show you a little bit of examples of our first 500 patients that we did, some of the things that we learned. The technologist role in this is so very important. And I'll show you a little bit why. I'll show you a little bit about what to expect. And I'll tell you from our experiences of who, what, and how to perform cardiac PET, show you some case studies, and a little bit about what's coming, I think. We have an active research project going on right now. So a lot of times with this discussion, I'm talking about coronary flow reserve and viability, with FDG and things like that. But we're really only going to talk about ischemia. I will tell you, talk just a little bit about a new research agent. Lantheus, or fluoroperidaz is an F18 labeled cardiac perfusion agent that is currently in phase 3 trials. They finished the first phase of phase 3, and in the U.S. you have to do 2 identical studies. They're about to start the second part of phase 3. Now, the important point of this, we'll get to this. Here's our example of our PET scanner. As I've talked about before, here you can see our as you look at this, we talked a little bit about how large a field of view is on a standard camera. Well, this is our field of view. You can get the entire lungs in one bed position. So that means instead of this, typically you're not like this for Philips and not like this for GE. Well, we're here. And that costs a little bit of extra. It's an extra real detector. We did that as a patient flow issue. My technologists don't have to worry about missing the heart. Here's the top of the field of view, here's the bottom, heart smack dab in the middle. There is no way to miss the heart. I have a colleague at Harvard that has a GE system, and their technologists routinely clip a portion of the heart. Because you've seen these patients with large hearts. You have to pick. You're either going to cut off some atria to keep the ventricles, but you don't want to cut off the ventricles, but it's easy to make a mistake, and you don't know until the end, because all these are acquired in this mode. So, equipment needed, PET CT at my facility, as where you guys are very similar, I imagine, a physician has to be present. That's not very common in the United States. Oftentimes, the technologist and a nurse are running these types of things. You have to have an added software package. The software does not come standard with the equipment. The cardiac software and gating on the cardiac equipment is an extra. You need a blood pressure machine, you need an EKG machine, you have to have some sort of stress agent. We are now working on doing actually treadmill ammonias. We've added a treadmill to our PET imaging suite that we hope to have be able to do a treadmill. Our cardiologists want to see treadmill information on these patients. Typically, that's very challenging. You cannot do that with rubidium. You can only do that with ammonia. But as you can easily picture, if your half-life of your imaging agent is 10 minutes and it's not on site, and you have to get to that patient to 85% of their max, you have some scheduling challenges. You're going to have that dose where you can literally watch it decay while the patient's on the treadmill. So coordinating that is very, very challenging. So the 2 agents for ischemia commonly used are,
rubidium and ammonia. Myocardial ischemia occurs when blood flow to your heart muscle is decreased by partial or complete blockage of the heart's arteries. Decrease in blood flow reduces the heart's oxygen supply. That's how myocardial ischemia can damage your heart muscle, reducing its ability to pump effectively, efficiently. Suddenly, severe blockage of coronary arteries may lead to heart attack. Myocardial ischemia can also cause serious heart rhythms, which is why we do EKGs when patients come in with chest pain, nausea, and really a variety of symptoms. And often, the symptoms are different in men and women. The United States has worked very hard on this lately, that they found basically the first 40 years of data studies were basically done on old white men. And they realized that other nationalities, other cultures were not being taken care of properly. So then they started figuring out on women, on African Americans, Hispanic Americans. They really needed to understand that different cultures can respond to pain differently. So these are important patients to capture when they present to our emergency rooms and physicians, because they have a significant risk of sudden death. However, many conditions can represent similarly. I'm sure many of you have done heart procedures or nuclear cardiology on, it's a GI problem, and we're trying to make sure that patient's safe. So in the U.S., the government tracks and keeps track of normal heart catheterization rates, because heart catheterizations have an inherent risk. That is an invasive procedure. So if there's a way that we can reduce normal caths, we want to do that. So to be clear, acute patients go to cath. Somebody comes in with crushing chest pain, elevated lab work, and EKGs, they're going to go straight to the cath lab. No doubt about it, they're going to get a heart catheterization. Patients with EKG changes and elevated troponins go to cath. So what happens to the rest? Well, typically patients that come to the emergency room, the low-risk patients, often get sent home. Well, and then the moderate to high risk, we frequently do stress testing. So for us, we perform cardiac PET on patients with a BMI over 40. So soon, we will be lowering that to a BMI of 35, undergoing a chemical stress test. And simply, the reason that is we don't like how accurate our nuclear cardiology is in doing a chemical stress test on obese patients. You have too much gut, you have too much false negatives, you have too many problems. And in my facility, we use oftentimes for nuclear cardiology basically a combination of a walking chemical stress test, which I don't know if you guys do that here, but we feed all of our patients. We provide them a meal after the stress testing. We try and do delays and repeat exams and all of these things, which is very time consuming. The technologists in my facility are very particular. They want a very good exam on that patient, which can end up taking 4 and 5 and 6 hours. You're trying to do delays and see if you can get rid of that bowel or gut or liver. So average patient for a female, this is 162 centimeters and 107 kilograms. So it's in men, 175 centimeter man would weigh 123 kilograms. So these are fairly large people. And we do these on outpatients and inpatients alike. So on the ischemia agents, for ammonia, which is what we currently utilize because we can't get rubidium, is half-life is 10 minutes. So that's pretty quick. When we're used to doing technetium or even FDG, this is cyclotron produced. Sorry, my slides are getting a little squished here, but which means basically the cyclotron makes, for each beam, you make 1 dose. So that is inherently labor intensive because obviously you need 2 doses. You do a rest and then you do a stress. So for rubidium, the half-life is only 75 seconds, which makes it very energetic. But the great thing about it is the generator's sitting in the scan room. So all you have to do is you hit the button and leave, and you're not even there when the doses go into the patient. So that is a really beneficial part of rubidium. So, I snuck in on my scan room technologists, and they weren't very happy with me when I did this. But just to give you guys an idea of what's going on. So here's the scanner. Here's a nurse. Here's one of my technologists, and I'll have another technologist sitting here. This requires 3 people, which I think is very important. So you have a blood pressure machine. The camera, as you'll find out, it actually has an EKG attached to it, so you can see the rhythm along the top of the machine, which is very nice
have to leave for the CT, you can still see that you have a good EKG. I'm actually working with Siemens to change the way this is going on, that you have an EKG in the room, in the technologist workroom, that can look at rhythms and make sure the patient's safe and you have to step out. You have to step out. So you have technologist, patient, EKG nurse, you have an EKG machine, you have to have a computer, we have to input, you have to have, this is our, as we talked about, you have things for ventilators, you have suction, if you're going to do a stress in a PET scanner, you have to have these safety devices. You got to have oxygen. You got to have, especially the suction. You can have somebody start vomiting and their legs flat, and you have to be able to take care of them and save their life. So as you can see, we talked about the large field of view. You get all the liver all the way up through the chest. And then, protocol. So as you're setting up your PET scanner, you can choose to do this way. This means that you get everything in one shot. So the technologist goes topogram, you do the CT, you have a pause built in, PET scan, topogram, CT, pause, PET scan. So everything is just very linear. It's very difficult to make a mistake because you just move the next. Just keep on moving right along. And setting this up is just easy on the staff. So protocol, as we talked about, it's 25 millicuries that we use for ammonia. We scan them for 10 minutes, and then we use regadenoson, or I think it's called something different outside of the U.S., but basically you can use anything. There's a lot of very well-known institutions that still use Prasantine for this. They like to see the motion still going on during the exam. They want to see wall motion abnormalities. My facility likes to do Lexiscan. We just feel it's generally safer. Prasantine and adenosine just takes too long. So all data is acquired in list mode. That's an important thing on the PET scanner. That means that basically you get the whole body of data once you hit the start button till the end, and you can do with it whatever you want. You set up protocols. That's the other nice thing for the staff. When you're reprocessing, you can have all these automatic reprocessings. So you just basically go in, take the patient, set up what you want to do, the resting, hit the button. Technologist does it again for the stress, hit the button, and it's very simple. It makes everything you need for the physician. You send it to the physician, and they read it. So in ischemia, and I like to say community hospital approach because we're similar to some of your facilities. My hospital does everything. We have just a little less than 1,000 beds, but you're seeing cancer patients, heart patients, everything. So we believe cardiac PET CT is best way to image large patients, without a doubt. Traditional stress testing falls short on radiation dose, image interpretation, and we like to do our bigger patients in multiple days. We try and do 2 separate days. Often we do the stress imaging first to see if we can not do the rest. I'm sure that's similar to what you guys do. But an interesting thing, a lot of times when we're thinking about PET CT, we think the dose is higher. Well, in fact, we did a pretty large project. The dose for cardiac percent is 80% less than nuclear medicine. So it's a very important point. If 30 millicuries, which is probably dose heavy for here, but this is common in the U.S. and people even do 40 and 40. That's 12 millisieverts. Well, 25 and 25 ammonia is 3. So you're 80% less dose to patient, and you'll see a lot of facilities, especially female hospitals, switching exclusively to PET because you don't want to image younger women with that high dose. And as we talked briefly about yesterday, this is a big cardiology organization in the United States. It's guidelines state 50% of your nuclear cardiology procedures, and they include PET in this, should be less than 9 millisieverts. And I can tell you that is a challenging goal in the United States to move under 9. That is very hard. And as far as image interpretation, it has increased spatial resolution. With cardiac PET, you have less bowel problems, and I do have to say less. You do have some still problems with chemical stress testing, and you have far less artifacts for breast, tissue, chest problems, because you have simply a more robust energy for detection, and you completely eliminate multiple days. You can now complete a patient in an hour, whereas the nuclear cardiology could take, well, if you're doing the one-day portion, it can take 3 hours, 4 hours, things like that. Those lines. So I'll show you some examples. This is an outpatient that was 58 years old, referred to molecular imaging for evaluation of chest pain.
After reviewing with his referring physician, we felt cardiac PET CT was most appropriate. So we'll start with just images. I like pictures. So I think it's, one thing to notice on this when you're looking at this compared to nuclear cardiology is this is excellent image quality. You can see you have very clear, you can see the chamber very effectively. A lot of times in nuclear cardiology, this is blurred. This means that you know you get good spatial resolution. If you're looking at the chamber and you see background, you know that that's what you want to see. Well, obviously this is resting, so rest, 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 stress on the top. So you can see full, obvious defect on the stress. Very easy to see. Well, the interesting thing about this patient is 160 kilograms. So this is a very large patient, and it's the same height as me. So, this is my technologist made this sheet, just so we don't forget things, so we know what questions to ask, and they may do the questioning. You can basically do a chest pain, family history, things of that sort. So basically, here's what the doctor said. You were able to, get an abnormal stress test, and then he goes to heart catheterization. That's the next step. So in this patient, he had a 99% stenosis in the right coronary artery. So you took an outpatient, which was a very large, unhealthy person, in for an outpatient diagnostic procedure, and now he's getting a stent. Obviously, that's a change in management. This patient would be a very high risk for walking around for sudden cardiac death. Right coronary artery widowmaker, that is a very serious problem. So the image quality in this, 160-pound patient was excellent. It's completed in 1 hour. It led to 2 catheterizations, 3 stents, and excellent care. His BMI was 49. All this was completed as an outpatient. And as far as hospitals, we want to keep these patients out of the hospital. We want to treat them outpatient, keep them healthy, keep them at home, keep their family taking care of them where they should be. And more importantly, we intervene aggressively, fixing his heart, allowing aggressive medical management, and hopefully a lifestyle change in this patient. So I'll show you another example, a little bit dirtier picture, but you can still see the point of a more real life example. A 60-year-old man went into his primary care physician, and they had an EKG done. He was referred for a stress test due to his risk factors and an abnormal EKG. Obesity, family history, hypertension, smoker EKG. The conversion to kilograms would probably be about 155 kilograms in this patient. So still a very large patient. There's his worksheet the technologist filled out, and you can still see once again stress on top, rest on the bottom. You can see he has a little bit of gut activity, still a little bit of fixed defect, but still much more going on. And it's on multiple views. You can see it's missing here, it's full filled in here. So it's still good image quality. You'll find that the bowel uptake is still there sometimes. It does still happen. So you can see extensive reversible. The nuclear medicine physician showed extensive reversibility, mostly imperceptible. So same thing, abnormal EKG in a functional study, shortness of breath. Once again, RCA completely occluded. So this patient had no flow in his right coronary artery. He could have walked out of the facility and had a heart attack instantly. It's totally blocked. It's amazing he was walking around. So once again, imaging allowed us to show lesions, led to a good outcome for this patient, and once again, completed in an hour. So for our inpatients, we like to keep them in the hospital. We utilize an observation system for patients that come through our emergency room. These patients have moderate to high risk of coronary artery disease, but no testing or labs to show a myocardial infarction or really a problem. This is typically troponins or CKMB, something like that. This happens to us 3 to 15 patients a day. So as your technologist, just so you get an idea of my facility, these 3 to 15 patients a day typically get added in the middle of the night. So when you come in the morning, you just have 3 to 15 patients to add to your day. So that's how it works at my institution. We try and be as aggressive as we can, but that is a very challenging. A hold technically is a way to not admit a patient, but to observe them. We like to watch them for 23 hours, put them on a heart monitor, check their labs, blood pressure, testing, etc. And they're billed as an outpatient. The purpose of this is to make sure people are safe and very efficient at this. To show you an example, 68-year-old man presented to the ER with presyncope and right arm tingling, atypical pain for a patient. He had obesity and hypertension. This would be about 149 kilograms, somewhere around there, patient. As I said, all inpatients ordered for stress testing with a BMI over 40. We do PET CT, cardiac PET. Sometimes if they can walk on the treadmill and the cardiologist wants them to do that, we perform the test that way. So the patient is put into our observation unit. Our nurses watch them very carefully. And then stress test was ordered, EKG and troponins, which all of the EKG, echo, and troponins were normal. Observation status that you can show. So the picture of this one, you can see it's kind of hard to see in that shot.
A little easier there. This is a little more nuanced, but as you can see, the resting here, thinned out at the apex of the heart. So that was read as abnormal. You can see it's multiple views. This is the stress here. You can see it's thinned and full on the rest.
We actually, for this patient, there's another view kind of blown up. As you see, stress, thin, resting, full. That was read as abnormal. 2 to 3 segment reversible change in this patient. So this patient, questionable angina equivalent. They weren't real sure what to do with this patient. So the perfusion study suggested an anterior defect. Well, as with a similar patient, this patient had a complete occlusion of the LAD proper, which is interesting that it didn't have more defect on this imaging. So for LAD, you don't really do stenting. This patient then goes for bypass. So we caught this disease early enough that this patient was able to get single vessel bypass, which allowed him the best options. And they moved on. They did a lima to the LAD, basically bypassing, taking a graft from his leg, putting it into his heart, able to move forward with a cardiac bypass surgery. So to clarify, this patient came into the emergency room with arm pain, was put into observation, normal echo, labs, EKG. Cardiologist said questionable anginal equivalent. He was deemed low to moderate risk. Performed cardiac PET, which led to a cath. Cath led to single vessel bypass. All performed within 48 hours. And that's what we try and do, especially for these heart patients that are really dangerous. They can go downhill before you get a chance to intervene on them. This led to excellent care, all started by his cardiac PET. And a lot of times we did a news story on this gentleman, but I'm not playing that here. So I do want to show some problems. This test is not perfect. There are several things that are technologist driven. One big issue with cardiac PET, especially with ammonia, is an anterior lateral wall problem. The second similar concern is the CT correction issue. So for example, earlier in our experience, in our first 500 patients, we performed cardiac PET on this patient. So this is a female, short female. She's probably 120 kilograms. As you can look at this imaging, the stress is on the top. The rest on the bottom, you can kind of see a bulging just so your earth has papillary muscle. There's such good resolution that you can actually see that contraction and show up on the imaging. So you see this defect at stress compared to rest. So on this patient, this was probably, I think, the 50th patient we did. So that was read as abnormal. And it would still be read as abnormal. So as the radiologist report, this was inducible ischemia based on anterior lateral segments. So she was sent for heart catheterization, and we track all of our cardiac PET scans to known heart caths. The technologists that when they have some downtime, they go back and research patients to see how well we're doing, to see how well the cardiac PET and anything that we can compare it to, we do. When we found they tracked down this patient, this is her cath, completely normal. So then when they brought this back to my attention, and we have a technologist board that meets to review these things, and when I go and hear their report, and we talked about this. So then I said, well, let's go back and look at everything. So here's the interesting thing, as you're moving into cardiac PET, an interesting point, as you look at the difference in the CT and the PET data. So you have to remember, CT is used for the anatomy. The PET is just detecting what's coming out. Well, the heart's beating. So the heart is in constant motion during this. Remember, we have a 10-minute PET acquisition. So we have that heart beating for a longer time. Well, we have a fast CT, as you guys do, on your equipment. Your CT is only 8 seconds. So it's real quick. So if you're looking at this, you can see the heart here, and you see this area of activity with no CT component. Well, that means that then the system doesn't know what to do with that information, so it cuts out. It doesn't allow the image to come in at that anterior lateral wall. So we worked with Siemens, our vendor for this, to find a way to figure out, is there something that we can do? This led to a new quality control measure for the technologists. It also helped Siemens to find a way for help to reprocess this data again, to reprocess it without the CT. We had to ask the question is, can we only reprocess the PET data? Can we just look and see what's going on with that? So this is an area that we've improved in the anterior lateral wall. And after this, the Siemens has put out a white paper on ammonia and anterior lateral problems. And this is to show you this example. This is after that. You can see similar problem. You have not so much a defect, but a thinning of the stress, normal at rest. The problem is when it's on multiple views, you have to say something about it. We want sensitivity, and specificity is what you kind of lose sometimes. So we worked with the equipment vendor to build a way to process the PET-only images. So you bring that same patient back. No, you don't have to bring him back, excuse me. You put him back into the system, and you reprocess doing PET only. And then it fills back in. So you see there's no problem. That means that patient doesn't get a CAT. So they don't move on for anything else. It's read out as normal because now you can say with confidence that the anterior lateral wall based on the PET data is full. There's no thinning, there's no possible ischemia, there's no problem. So although cardiac PET is a powerful imaging procedure, it is only as good as the physician reading and the techs running the equipment. All patient must be tracked and compared to gold standard, in my opinion, and we must continue to learn better ways to image. And I'll quickly go, I think I'm going a little over on it. Just quickly talk about the research. Lantheus is a proprietary agent. F18 labeled perfusion agent. That means it can be distributed all over the world. That means that your half-life is now 110 minutes, not 10 or 75 seconds. So that means that you then have time. You can do treadmills easily. You can, put that patient on the camera when you have time to do it. So it allows for really almost anyone to do cardiac PET imaging. So we're participating in this trial, and the endpoint is to find an F18 labeled coronary disease agent that's mass marketable. It's that you can basically have the time to ship it anywhere you need. So the study is for diagnostic efficacy. For these patients, it's a really interesting study. Every patient gets a nuclear cardiology exam, every patient gets a cardiac PET exam, and every patient gets a CAT. So it's all done blinded. One doesn't know what the other one is showing. So it's a really good way to go through. If the nuclear cardiology is positive, the PET's positive, the CAT's positive, great. Well, if the CAT's negative, then you have a problem. But these are thousands of patients going into these studies, and hopefully within the next few years, it will be available to everyone. So this material is unique. As I said, treadmills. There's still yet out there, for imaging stressing people, there's very few things that are as effective as the treadmill. That 1 minute post-blood pressure EKG and changes and whether or not that patient has symptoms on the treadmill is still probably the best way to figure out if someone is safe for the next 12 months. Their workload capacity is so important. As I said, worldwide distribution. It has a very high extraction rate, even better than ammonia rubidium. Up 90% goes into the heart. And then common sense, if then 90% goes into the heart, your dose then goes down dramatically.
That's the problem. It's dose to background. We've heard many discussions about that. If all your dose is in the heart, you don't have background. So, it just, it's like the lungs. You can see that lesion down to 1 or 2 millimeters because it's surrounded by air. That's just the common sense of imaging. The cons, you still have that attenuation correction. They had to redo phase 1 of their trial because technologists could not figure out how to fix the CT and the cardiac, the PET agent. The PET couldn't fix them together when there was a problem. They had to redo it, the whole study. So cardiac PET is a challenge in manipulating the CT and the PET, figuring out how to do that in a way that you can move forward and learn from. So cardiac PET is effective, innovative test that is great for your patients. That's all I have. Thank you.